Don't lose points come exam day on these really important respiratory auscultation findings. So before we get started, pause the video, go through the question, do the answers by yourself, and then I'll walk through it with you. So we have an 18-month-old girl, okay? She's brought in by her parents with a 36-hour history of a high fever. So this is about a day and a half of a high fever, so quite acute, of 39.5. So remembering a high-grade fever is anything over 39. We have increased breathing effort and intermittent grunting. So an important question is, why do children grunt? So children grunt to maintain their positive end expiratory pressure, which keeps their alveoli open, okay? We also have a mild cough, and she appears lethargic, pale, and is breathing shallowly. And important to note, on auscultation, there is no abnormal breath sounds, okay? So what is the most likely diagnosis? So we can see, first of all, think about, what should be going through your head is that this child is quite systemically unwell, okay? So when we're going through the answer options, think of that. So first of all, acute bronchitis. So this is incorrect. So this usually affects larger airways. It's usually viral in nature, okay? So it'll be more of a gradual onset. You'll see coryzal symptoms, so like a runny nose. You can see a cough. And on auscultation, you'll hear coarse crackles, and you may also hear sometimes a wheeze. So just to go through as well, some common some common confusion is between rhonchi and rales. So they can be used interchangeably. Rhonchi can be used interchangeably, usually with wheezing, and rales can be used with crackles. Okay, so I know a lot of respiratory physicians are starting to move away from those terms because they're quite old. B would be bronchiolitis. This is incorrect. So this is in the correct age group, actually. We usually see bronchiolitis under the age of 2. Okay, it's usually viral in nature because, or it's usually caused by RSV. On auscultation, you hear a polyphonic wheeze, fine inspiratory crackles, and sometimes some reduced air entry. But we obviously didn't hear anything there. Children can be systemically unwell like this, but it's usually they will have a low-grade fever, so under 39. They usually also present a little later than 36 hours. I'll also walk through at the end what the difference between a polyphonic and monophonic wheeze is, and also walk through biphasic and inspiratory versus expiratory. So C, lobar pneumonia, this is actually the correct answer. So we have a child who's systemically unwell, high fever, lethargy, and grunting. So things you may expect to hear on auscultation finding would be reduced air entry. You can sometimes hear some crackles because you have all that mucus in the lungs, and you can hear bronchial breath sounds. So in children, you can actually hear none of these findings in pneumonia, especially when they present acutely like this. But from all these answer options, this is the most likely answer. So quickly go through the rest. D, asthma. So this is incorrect. So usually you'll hear a polyphonic wheeze. It's usually diffuse and it's expiratory in nature. It's pretty rare to diagnose kids under 2 with asthma, and it wouldn't cause any fever or systemic features like this. And then foreign body aspiration or inhaled foreign body, usually sudden onset. You get a monophonic wheeze and usually unilateral reduced air entry. Okay, you wouldn't expect to see these infective or systemic features either. So I'll quickly go through monophonic. So monophonic meaning single pitch. So usually it's a focal obstruction, either by like a foreign body, as we mentioned. Polyphonic means multiple pitches or multiple tones. So usually a diffuse narrowing. This can be due to most common is asthma. You can also hear it in bronchiolitis. So then we have biphasic versus monophasic. So monophasic can mean either inspiratory or expiratory, usually in relation to stridor. So in stridor, remember we have a closure of the upper airways. So this is usually inspiratory can be extrathoracic. So this can be laryngomalacia. So that's when the larynx is closing. Or we can have croup, where you have that characteristic barking cough. We have expiratory stridor. You can see this is usually intrathoracic. This can be like tracheomalacia, so when the trachea is collapsing, or we can have biphasic. So this is usually a fixed obstruction at the vocal cords or subglottic area. So something like subglottic stenosis, but you obviously wouldn't expect to see that in children. So guys, just so you know, so if you look on the Royal Children Hospital Melbourne, if you look on their website, they have some really great guidelines in relation to pediatric guidelines. So you can find things on bronchiolitis, asthma, acute bronchitis, all these different things. So it's a really, really great resource if you wanted to study up for the AMC. Thank you.